Okay, we're live. No countdown today, people. Apologies, I'm a little bit late. 4 minutes past. I'm so sorry. 2 minutes, cool. 3 minutes, not so much. 4 minutes, just rude. So apologies for that. But welcome to episode 253 of the Sports Therapy Association podcast. My name is Matt Phillips, creator of RunChatLive.com. And as always, this episode is being recorded live on the Sports Therapy Association YouTube channel and Facebook page, normally on a Tuesday at 8 o'clock, but tonight we are going out live on a Wednesday, but next week back to the Tuesdays as normal. So thank you for joining us. If you've joined us live, thank you if you listened to the podcast. We are going to continue our countdown to the STA Southwestern Hands-on Hub Conference, which is happening in Exmouth this September the 20th and 21st in collaboration with the ST School. So yes, less than 3 weeks away now. It's going to be amazing. I'm obviously biased. I'm emceeing it and I'm presenting there, so I'm biased. But I don't know. After 257 episodes, hopefully you can believe when I say it's going to be an amazing weekend of presentations with workshops and networking. And in this episode, I'm going to be talking very shortly with Dr. Claire Minshull, rehab and conditioning specialist and founder of Get Back to Sport, and also Serena Simmons, chartered psychologist and founder of the Psychology School, to discuss what they will be delivering at the conference later in September. Last week, in case you missed it, just a huge thank you to Michelle Lyons, women's health physiotherapist and founder of Celebrate Movability, whose conference presentation in September is The Menstrual Detective, Why the Fifth Vital Sign Might Be the Missing Link in MSK Health for Female Athletes. Michelle was joined by guest Siobhan O'Donovan, aka the Booby Physio, and founder of Posture Fitting. And Siobhan is going to be presenting Bits and Boobs and Bumps and Babies. Wonderful alliteration there. And as always, that episode is on all popular podcast apps and YouTube if you want to watch the video, and also at the STA website, thesta.co.uk. Just to keep you in touch of what's happening in the lead up to the conference, next week I'm going to have the one and only Anna Maria Mazzieri on the show, director of the ST School, who's going to be chatting about the conference, but in particular something that was brought up in one of the debate panels we had with experienced therapists and less experienced therapists was, what the hell is evidence-informed practice anyway? What does it mean? It's all very well when more experienced therapists goes, oh, you have to be more evidence-informed. But a lot of younger therapists, less experienced therapists, are like, well, what? What do you mean by that? So we're going to have a little chat about that with Anna Maria Mazzieri, who has a fantastic course on this, or workshop on this, at the ST School. And also two of her presentations are very much about that at the conference, which are going to be When Pain Echoes Trauma and When Massage Echoes Embodiment, and also Massage and Manual Therapy for Scars. So that is next week. Hopefully you can join us live 8 o'clock on the Tuesday. And then the week after, we have the wonderful James Earls of Born to Move, who's also going to be speaking at the conference with a presentation entitled The Knee, Why Do We Have It All Back to Front? Again, I could go on forever about James, just the approach to anatomy which you need, and put forward in a style that's not going to make you think, I'm going to give this all up, this is all terrible, I'm going to sue the people who gave me that last course. Not at all. It's just tweaking it a little bit to help you and, most importantly, your clients. So again, a wonderful speaker in the lead up, and that'll take us to the actual conference, which, like I say, is on the 20th and the 21st. If you can't make it, please don't sit there with FOMO, fear of missing out, down with the kids. We're going to make this regional. The whole idea of this conference is to try and do something which people can travel to in the same day, maybe don't have to stay the night. So we're going to be moving around the country. We're going to be moving, hopefully, to Ireland at some point, up to Scotland, and maybe even abroad. Who knows? The world is our oyster. Right, I've left my guests down in the lobby for long enough. If you do want tickets to the conference, I'll repeat this afterwards, but just go to the stschool.co.uk. And if you're an STA member, remember there is a discount code, which you'll find in the latest STA newsletter or on the Facebook members group. But for now, allow me to bring up my guest for tonight, Dr. Claire Minshull of Get Back to Sport, and Serena Simmons, chartered psychologist and founder of the Psychology School. Let's bring them up. Hey there.
Hello.
Hello.
I'm still red because of what you said before we started. You really shouldn't kind of make my head swell like that with compliments just before we go live. Please don't ever do that again. That's what I was thinking of. Anyway, but I'm really thrilled to have you along. Thank you so much for joining us.
Thank you. Thanks for the snacks and the lovely as well.
So as we chatted off air, I'm really hoping, I'd be surprised, but I'm really hoping that some of the couple of thousand downloaders we get don't know you guys. Some will, but I'm hoping that we're going to reach out to people who've never heard of you. So to do that, we need a little bit of an introduction, which is tricky because, you've been in the game for a long time and it must feel like just a nightmare going through. Well, once I got injured and no one sorted me out, and so I did this, which is normally kind of the story. But so I thought we'd do it slightly different with a few images, which I think might help us kind of present you. If that's okay.
Embarrassing.
No, not embarrassing. There's no embarrassing pictures of you.
Ask Claire
either of you.
Robertson. She's embarrassing images of me.
So let's just bring this up first of all. I mean, I hate to start on a sad point, but podcast listeners, you won't be able to see the images. You might want to stop now and go over to YouTube. But essentially what we've got here is a series of you describe what's going on. We've got a pretty bruised up, nasty, stitched up wrist going on, Claire. What happened?
Fat hand. It was well intentioned. So this is the end point of my rehab journey this year. This was me trying to break up a cat fight of my own cat bullying the neighbour's cats. Just instantaneously, just jumped in because he just jumped on her, and in full fight mode, he turned around and bit me right down the bone.
That's good. That's me. Carry on.
Not me, thank God.
That was my cat.
I've since learned that cat bites can be really, really dangerous and not just painful, but so I went to A&E, and within 24 hours I was in surgery. I was in hospital for 3 days.
So let's just break that down a bit. Surgery for a cat bite.
Yeah.
What happened then?
Let me provide some education about cat bites that I've learned. First and foremost, if you're going to approach a cat fight, use a super soaker or a bucket of water.
Wow, she really is going to detail.
Yeah, well clear, because cats have very sharp teeth, much sharper than dogs. They're very able to penetrate more deeply. Hand injuries from cats are very common. So in A&E, I was one of 3 people. On the ward, I was one of 2 people who'd had surgery. And not only can they penetrate deeper, they have particular bacteria on their teeth, which then obviously is entered into the tissue that it penetrates. Fortunately for me, it wasn't in the joint. Unfortunately for me, it wasn't in the bone. It went into the tendon sheath. But within 24 hours, it's extremely infected and there's some horrific reports of the consequences of cat bites if left untreated, and even to amputation point. So if you get bitten by a cat, just straight away go to your nearest A&E, that type of thing. Within 24 hours I was in surgery, and phenomenal kind of service from the A&E. That was just amazing. Saved my hand. So
I'm smiling. I shouldn't be, but I just love the way. I shouldn't be surprised, but I love the way you make it so interesting. I mean, even when you're talking about cat bites and a trip to A&E, I'm sitting there thinking, this is great. I hope she does like a kind of workshop on this, because I really want to attend. It's like, so that's why I'm smiling, because it just sounds so informative and interesting, and I want to sign up.
I didn't really want to learn about it in that way. Have to say,
especially as if we go back a little bit.
There we go.
Again, if you listen to the podcast, you can't see us, unfortunately. This is why you need to join us live. Get back into what we used to do, when you actually turned up in person for something. But we got lovely Liz Bailey there, and James Noakes, and your leg, I think.
My leg. And just a big shout to James Noakes, who's going through the phenomenally difficult time at the minute with his back disc infection. He's the most knowledgeable, kindest sports med doctor I've ever. And he's struggling a bit at the moment, and he's just been those guys phenomenal. And especially James is going through a really, really difficult patch. So I think I had it hard, and he's laid at multiple hospital admissions. If you follow him on Twitter or X, he's publicised his journey. So big love to James. Yeah. So that is a bone stress injury to my right talus, and probably more also a anterior capsule injury as well. And so I was a month on crutches. We tried to manage it with reduced loading. So I do a lot of lifting, compressive loading, running, cycling, that kind of stuff. We backed off for a couple of weeks. It didn't didn't settle. So yeah, I was 4 weeks in a boot on crutches, which was so joyous. Yeah, so I'm playing Rehab Twister right now with my right foot and left hand. Don't really know what I've done to spin this, but yeah, yeah. So
But it
that's that.
is,
I've
I
got
mean,
full.
it's sad, but it's great. It's not entertainment, it's the wrong word. It's very educational for us because you're documenting this all in your social media feeds. We're seeing ski pulls, we're showing different hand
Oh yeah,
grips, we're seeing all sorts of stuff, which, and it's, or as always, inspiring. I mean, yeah, I wouldn't wish it upon you, obviously, but as always, you're turning it around into something which is helping others. You just can't help it, can you? You're just a
well,
giver.
also, it's anybody that exercising that's a part of them, you find a way. Otherwise, it's even more traumatic. So yeah, trying to find different ways of doing things that you can for mental health, absolutely important, and also physical health too. So I didn't really need any more experiences on the patient side of that model. I've had plenty, but I've had them, and so there you go. I'm
It's
I'm
true.
at the other side.
It's true. In fact, yeah. I'm thinking back to your because anyone who wants to catch up with the first installments of Claire's journey through rehab, then check out the first couple of episodes and you'll hear it way back at the beginning where it all started. So in the meantime, whilst you were all suffering with this and going through different areas of rehab, it's quite a nice segue into, let's go over to our other guest, Serena Simmons here, to see if there's any parallels. What picture have I got here? Let's just go through here. Right, again, if you listen to the podcast, you won't see what's on the YouTube screen, but essentially, I'm just going to describe what I see and then you can explain, Serena, what's going on.
This is pesky.
If anyone's a Dexter fan, then yeah, basically we've got a kill room. We haven't got the cellophane, but it looks very clean. And all I can see is Serena dragging a wrapped up body. Over to you, Serena Simmons. Who are you and why are you doing this?
I feel like I'm a blind date. Who are you? What's your name? Where'd you
Yeah,
come from?
this is a great intro.
I'm Serena Simmons. I've killed someone. No. So yeah, thank you. It's nice to be here. This is a very pesky picture here. So I had a lot of fun this weekend. I'm just about to do some teaching on the topic of body disposal. And I can say no more at this point other than I'm trying to convey how we dispose of a body. And the reason I'm doing that is because my background is in forensic psychology and in particular a speciality in serial murder. And I hope that we get to segue into why I'm coming to the conference and how I'm going to deliver something of value to the physios and the people, not physios, but people in the arena who want to learn more about how we can incorporate psychology and behaviour change into practice based on my background. But yeah, I'm basically manhandling a fake dead body in a picture that people can't see.
Brilliant. I'm just going to pause for people who will ask the podcast to get over to YouTube. Just give you a few seconds to catch up with this. They're back. Let's stick with that and go into a little bit more of the link. So from forensic specialist in serial murders to helping clinicians in healthcare.
Thank you for asking the question, because I think the jump seems really big, but I think so. Essentially, my background and training was all in forensic psychology, and I followed a forensic pathway in my training for a long time. So I worked for a long time for the prison service. So my initial job was I was the manager of all of the cognitive behavioural programs being run in the UK for prisons in the UK. So I managed everything that was cognitive behaviourally based. And I then went on to work in practice at Rampton Hospital, so some of the most dangerous offenders basically in the country, with my own caseload of patients and group therapy. And I think what people often don't realise is when you work with those really dangerous people and you're working in that arena is that your main job as a psychologist in the UK is to rehabilitate. And so actually your job is to change the behaviour of some of the most dangerous people that we have in terms of what they've done. So we're talking, I don't know what I can say in terms of like certificate 18 or not.
Oh no, we've had.
Oh,
Yeah,
we're good.
you
Okay,
can go
good.
for it. Yeah, I had to
Okay,
tick that box
great.
in YouTube.
Oh,
Yeah.
love it. So
Ever since Alice Sanvito told Adam Meekins to fuck off, I've had to basically make it an 18. So yeah, you go for it. You go for it. It's
I can
fine.
go for my life. Okay,
Yeah,
ready? No,
it's
okay.
fine. Yeah.
So basically, the three main groups of people you work with in a setting like that are typically those who've committed rape. So rapists, paedophiles, and murderers. And my speciality being murder, serial murder, is the area that I come from. And so as I began to work more in the area, it was people that approached me to say, how do, if you've tried to change the behaviour of those people, how do we do it for these people? And it was really healthcare, although I've worked in healthcare since I was 17, actually. Healthcare found me, and I was able to translate what I've learned from that arena and bring it into something really positive. And so actually now I spend half of my time working still in that area, and mostly of profiling. So I mostly profile offenders now and do kind of teaching in the area, but then I bring that into this really beautiful area of positive behaviour change in healthcare.
Fascinating journey. And now you've explained it, I'm hoping people can see the link there. And it's a very topical thing at the moment, because we are realizing, and we've had people on the show before talking about the importance of psychology and behavior change and how important that is to do with therapeutic alliance and using your eyes and your ears and your hands, your mouth just as much as your hands, if not more.
Yeah.
But I've noticed you have said, I've read it a few times, or maybe people talking about you, an actual psychologist teaching the psychology behavior change, which I suppose is quite thrilling for you, because being a psychologist, you've got that upper hand. You kind of...
Yeah, and I don't mean that I would say the same thing. I would say, for me, when you're working with a person, first and foremost, we have to honour the person. And I think anyone knows that. But when you have an understanding of someone's psychology, you have a better understanding of their thought processes, how they think, and therefore how they behave and how they respond. And so I think what psychology does is it goes beyond what could be quite a surface level approach to helping someone change. Because what you're doing is you're going way beyond that surface level technique, and you're looking at why someone is doing what they're doing. And when you know more about why humans do what they do, you have a much better ability to help them move the needle and kind of change something in their behaviour, in their rehab, in anything really. So for me, obviously I'm biased, but psychology forms the basis of all of that other good stuff.
Brilliant.
And just to kind of reinforce that, all the obviously amazing exercise prescriptions that I do for Joint Approach, which are phenomenally life-changing, would have absolutely no relevance whatsoever if patients didn't do it. And the reason why they do it is because of Serena's influence throughout the entire program. I know we'll get to this, but a point to iterate here is we had, in an NHS clinical trial, 0 people drop out, and that's unheard of. So it's profoundly impactful, and can pave the way. And it's like a symbiotic relationship, but it'll pave the way for anything that comes thereafter.
I'm going to say something else. I think the other thing...
Don't have to put your hand up, really.
Sorry. I'm excited. Can I say something? The other thing is you don't have, and that's the whole point of me teaching this to healthcare professionals, is you don't have to be a psychologist to be able to understand that. And I think that's the bit for me that I get on a bandwagon about. So if anyone has heard me on a podcast before, usually what I'm saying is everyone should know this. Like, if you're working with a human, you honour the human. You don't, like, it's a tendency to jump to our expertise because it's beautiful and we're excited about it. So I work a lot with, for example, physios or kind of surgeons actually, and doctors, and they want to do the thing that they were trained to do. And that's beautiful and it's brilliant, but we must first honour the person in front of us. And there's a way of doing that. And I think when you do that in a different way, if you do that in a very unique, individualized way where you're honoring that person first and foremost, there are things that anyone can learn to make that better and to, for example, to make it stick. So with the adherence, to make that kind of better, kind of over the long term as well.
So exciting. It really is, because it's so topical at the moment. Like I say, I think I wrote somewhere. I mean, I love listening to you because it explains something that I felt for a long time. Every time I heard people complaining about, oh, so and so, my client or patient hasn't done their exercises. How do they hope to get better if they haven't done their exercises? And inside, I always felt that burning thing of, hold on, if they haven't done their exercises, aren't you a little bit culpable? Isn't that something to do with you let your patient go and they haven't done? That's got to do something with the conversation you had or didn't have. So I think that's such a common problem. We talk about lack of exercise adherence being one of the kind of biggest delays to recovery, but now we've got something to get our teeth into with regards to how to bring this down, and actually through coaching and through psychology and
yeah, I'm going to pick up on something that you said, which is really interesting.
Why have I got a psychologist on the show? Okay, I'm going to lie down.
Now,
what did I say?
You said it's really interesting that maybe there's something you did or didn't do. And the thing is, I think the beauty of learning what I teach people is, I think learning what I teach about someone's psychology, it actually frees you up. Because what I don't want practitioners to do, anyone in any discipline, is to go in thinking that the onus is all on them. I.e., you can learn the tools, you can do the thing, you can do the learning. And actually, here's the Trojan horse that I always incorporate into my teaching is, actually, if I'm honest, a lot of the psychology that I teach is about you, it's not about them. And that's the tricky bit, is that, everyone's comfortable going in and learning a tool. If I said I'm doing something on motivational interviewing, I'd get loads of people sign up. If I say behaviour change, it's a great label. Lots of people sign up because it feels like the thing that will solve the thing. But actually, the real response is down to you working on you, really. And that's the pesky bit, is because it's how you're showing up in the work. And some of that looks like letting go of the results. Because actually, someone might change, but they might not, and that's okay. So there's a lot of psychology around.
It's deep, isn't it?
Oh, it's just beautiful. I just feel so calm at the moment.
Yeah, and that's the beauty of it. Is I think when I teach a lot of the students I teach, what's really beautiful about the teaching, not my teaching per se, but what people go away with is, it's like now suddenly the confidence goes up, and it's like what I try and instill is this beautiful curiosity about a human meeting another human being. And so there is nothing to get to. It's a bit like Yoda, a bit deep. Like, where are we trying to get to here? It's like, what are you really trying to do? What is this for? And so you start to kind of look at it in a different way, where you go with this kind of beautiful curiosity into a conversation. It takes so much pressure off them and you that it kind of creates a space for change to happen. And that's what I'm after.
Brilliant. I'm so happy
I'm going to stop so I can
go
on.
This is exactly what we're trying to achieve through the conference, because it's people say, what CPD do I need? What can I do with my hands? What can I learn? And it's like, no, turn that with some other guests we've had on the show. We're talking about turning that mirror, that lens round, and shine it a bit more on you. Stop 100%. Just looking at what's on the couch, whatever, and start turning it around. And that will help ultimately yourself and therefore the person on the other end. And that's what the conference is all going to be about. And the speakers we put together with, like both of yourselves and other people coming along, they've all already on that same page of realizing that they are experts, but it's not all about them standing on a stage and just vomiting out this information. It's about turning that lens around. So exciting. Beautiful. Amen, brother and sisters. Yes. I was going to do your course, but so annoying. But I didn't get on it. And no, it was on our list of things to do. In fact, Anna Maria was like, you've got to do Serena's course. It'd be amazing. Do it. Doors closed. Because it was so popular. I've got a son up here talking about it. So we're talking about behaviour change psychology for therapists, launched back in May, wasn't it? And it's kind of full, isn't it? I think I saw on the website that it's kind of no more applications yet until, I don't know what, 2029?
Well, I normally do one a year. I may do another one, I'll see. But yeah, we'll see how we go.
Oh, don't just do one for me, please.
You've got the other program
as well. I've got another program. Yeah, I've got a psych lab as well, which we can talk about later if you want to. Because I feel like we have to go. I can talk forever. So let's.
Oh, Dr. Claire Minshull as well. Sorry, Dr. Claire Minshull.
I enjoy this. I mean, it's impactful. It's changed my practice, and it's lovely to listen to. So,
but what you said is probably the most important thing so far, is that, and you admitted it yourself, for all the amazing rehab and strength and conditioning and protocols and dynamometers and different types and all of this stuff, it's all fantastic. But if you are trying to get the person on the end of whatever you're doing to do it, and they're not at that right state of change or behavior, you're preaching to ears that just closed and not ready, and it's
or you're not necessarily preaching. So if you're trying to elicit a response in terms of a strength test or an effort on a strength exercise, you have to have the engagement, and for that you have to have the right communication. So I thought I was pretty good at it before, and then with some helpful input from Serena, then I've become, much better at that. And I think that comes also with age and experience too. But that is the key, right? So you've got a person usually is a whole and complete being. I'm kind of incomplete at various points in my life at the minute, but with Neo 8, we're not just treating the knee. The knee is attached to a whole person, which is all the other musculoskeletal part of the system, plus their thoughts and feelings, and plus their life and logistics. So even if it comes down to exercise prescription, you go, right, this is the best exercise you can do, delivered in this way. I need you to do it. And then you go 3 times a week at this time, every day, or every session. And they go, oh, hang on a minute, I can't do that because of X, Y, and Z. You have to acknowledge what's in front of you. So it becomes a logistical challenge. I think the best, forgive me. The reason why we're at Wednesday is I was yesterday down at the MOD in Winchester teaching. So it's my bad. Forgive me.
It's fine. Honestly, at least I could do.
The point that I make in every interaction that I have the pleasure of delivering with anybody that wants to listen is that you can let's start out with what the optimal prescription would be for that. So if we need to get somebody stronger, and let's look at what's the best stimulus you could possibly deliver, dose response, to get somebody stronger, that muscle group stronger. Then let's layer on the real life logistics. What equipment have you got? Have you got no equipment? What environment have you got? What commitment have you got? And then we can work back from that. It's the whole person.
So cool. And do you think, I'm interested to know that ideally, should this be taught from the beginning? So like, imagine the traditional YMCA level 3 fitness trainer or something, which I did in like 91 or something. And there's obviously, back then, there was no talk of psychology or anything like that. It was just 3 sets of 10. And it was cool because it taught you like how to demonstrate an exercise in different angles and group exercise and a bit of exercise to music. So you had all of that going on. But do you think it would be too much to integrate something like this now about the questions that need to come before prescribing the exercise, or should we be putting it in that early on in the person's kind of learning path?
Do you mean the psychology bit and the
is it too much too soon? Does it need to be black and white?
My point being is, I think it very much depends on the environment, because you need to acknowledge where, as you were saying, Serena, where that person is at, where the learner is at. So if they are in a gym-based setting, you already have some buy-in from that person because they've come to the gym. Mm-hmm. If you're in an NHS setting and they've been told to come there by the doctor, you're going to have a representation that's much greater on that continuum of behaviour change. You might need more understanding, and also the risk reward or that balance is much greater. So what you could potentially lose by not doing this, or potentially gain. So I think absolutely yes. The levelness, I think, needs to be commensurate with the learner and the application. What were you going to say?
Yeah, I guess probably say the same, but I would describe it in a different way, which is 1,000 million% big fat yes from me. Yes, because I've never been able to get my head around the fact that if you're dealing with a human, that you don't do psychology first, personally. And I don't think it's just because of my bias. I just don't understand how even an injury starts in your head. as in, yes, you have the physical, but it's the human that deals with it. So they think about the injury, they relate to the injury. So you have to first deal with the psychology of it to help them with the thing. So how can you not be taught psychology? And it's no criticism of anyone listening. For me, it's a criticism of how things like degrees or training is structured, that this isn't incorporated. However, having done this for a long time, taught healthcare professionals in general for a long, long time, what I realise is not everyone is receptive to it. So I go into, say, hospitals and teach teams of people. And if I'm being really honest, and that is my normal MO, I get a group of 30 people. There'll always be those 5 people that are just rolling their eyes at me, going, I don't need that, don't want to hear that, don't want to learn that, don't care about that. My patients do what they need to, or actually I don't care whether they do or they don't. So I think that's replicated early on. I think you get people who, and I understand this, when you go to uni, for example, say if I'm teaching a physio, the physio wants to learn physio. They don't want to go and learn psychology. So their listening isn't open for what someone might say about someone's psychology. So what typically happens is people come and self-select into things that I might teach or other people like me when they think they need it or they've encountered an issue. And for me, I think it's only those that really want to kind of genuinely help the whole person and feel like there's a benefit to learning this that will want to learn it, or very early on see the merit in doing so. And so that would kind of knit in very cleanly with what Claire said. I would just describe it slightly differently. I think it's like anything at uni. We all do. I had to do statistics and research methods from year 1. And I absolutely hated it, but I had to do it to pass my degree. So like, I think it should be a part of our training. And it's like anything we learn, you just don't know when it will come in useful. And I think those that will like it will really like it. I personally think it should be integrated into everything. I think if you're working with a human, you need to know psychology, because you need to know how people think and feel and how they respond on a very basic level, at least.
I'm hearing Anna Maria's voice in my head, which you're going to an awful lot on September the 20th and 21st. But because she very much, I mean, it's more to do with learning about pain. But as soon as you start, pain's so complex, but if you really want to start understanding what we can, psychology is going to come into it.
Yeah.
And also these days as well, I mean, potentially the pendulum swung a little bit too far the way for some people, and now it's involving more the inflammatory system and other things which are being worked on. But you're going to have that biopsychosocial lens or appreciate what it is. And she would say, Anna Maria, that if you are going to make a living out of working with people in pain, then there's no excuses. You can't just say, this doesn't interest me now, I just want to do this. It's like ethically, you need to find out these things, be evidence informed, and start adopting a change in what the syllabi are kind of preaching at the moment, which is very outdated. Otherwise, don't work with people in pain. It's not a game, if you're mending cars
also from a business and reputational perspective, it'll become quite apparent that you're not making a difference to people, and you can't buy word of mouth. So you have a positive word of mouth or a negative word of mouth. I don't know if
it does though. I think there's still plenty of business models out there with the old kind of structurist approach to click, come back, see once. There's people who are still going to certain professionals.
Okay.
There's a massive buy-in, isn't there, from things you can't do to yourself.
I think a good model, a good frame of reference is if anyone feels like that about, say, for example, pain. And again, it translates well to like a training I might do if I do some quite controversial trainings, for example, like with groups of surgeons, who I find are one of the most challenging groups to work with, because their training is about doing surgery. So they are trained and they put so many years into learning a craft. It's art and science kind of coming together, and they put, so much into that. And I really respect and admire that. However, conveying to those groups of surgeons that I want you to think about just talking to people in a different way, honouring the whole human, giving the power back to the patient for them to maybe for example, even so radical, to do some exercise and physio before they resort to surgery. Heaven forbid I take kind of surgery out of their remit and give the power back to them. surgeons who are on board with that and forward thinking think that's great. But when someone feels that their power is being taken away, they don't want to kind of give that power back. And I think ethically, as you mentioned the word ethics, and that's really important to me, is ethically and morally, how do we feel, for example, when we sit with a surgeon, kind of going back to what you were describing with a doctor, if it's not just a model, it's not just the thing, it's not just getting, for example, the treatment, it's the human to human contact that matters. So yes, we might be fixed by going to the doctor and getting some pills or a paracetamol, but first and foremost, we want that person to respond like a human to us in terms of what we've experienced. And we're looking for that connection with that emotional and understanding first. So when you're looking at pain or rehab or surgery, we go and seek these experts because we're looking for more than the expertise, really, when we kind of look beneath it. It's not just the thing. Otherwise, we will have AI doctors. And actually,
this
we
is
are.
What I was going to say. I think there was a study.
We have got AI doctors.
I think there was an NHS study which showed that the survey showed they preferred the AI treatment they were getting, the triage they were getting, because there was just more empathy rather than the doctors, which was worrying.
But
and it's not, well, let's do AI then. No.
It's worrying, isn't it? Yeah.
It's really scary. But it shows the power of someone who's listening and looking after the language which they reply with and the questions they're asking.
There you go. So that's if the empathy is being picked up on, that is,
fascinating. Oh man, we could talk.
I know, sorry, I am
minutes about this. No, it's fascinating, and what I really love, and the reason why I'm so happy that both of you are on the show together, is because it's just not the two sides of the coin, because it all works together. It's the yin and the yang. It's the continuous flowing of the circle, because that's what it is in healthcare, isn't it? I know, I can't believe it's 2025 and I mentioned yin and yang, but we all had them, little earrings with a black and a white little thing going on. The first stud I had, I think. But yeah, it is. It's really cool, and it's something which I think so many therapists, so many listeners need. I get messages now from therapists who are just saying, basically, you know what, Matt, it was so much easier to make a living before this whole biopsychosocial thing came in. Starting to care about people. It's so much easier when people just came in and needed to be fixed. Bam, bam, thank you very much. See you in a week. Bam, bam, thank you much. Now I've got a conscience, and that's a shame, because it just means they haven't grasped that model change enough. There is a fantastic future in healthcare if you've got the skills and the empathy and the coaching abilities to look after people, but it is a different model, and you just need help from people like Dr. Claire Minshull and Serena Simmons, and you can start getting that help by coming along to great segue to the 𝐒𝐓 Devon conference on the 21st and the 20th on a weekend, which is nice, I thought, instead of midweek. Talking of which, let's tie this all in. I mean, this has been great, because the idea of tonight was to introduce you to everybody and give them a reason to potentially come to the conference or anything else you do with courses and things. So let's dive in, if we can, to what you are delivering at the conference in September. There are still tickets available, people. If it's the podcast, you can still get in. It's not unreasonably priced. It's more now than if you listen to me when I first mentioned it, but that's just organisation on your part. You're just gonna have to look at your time management a little bit, but you can still get a ticket. Okay, it's still possible. Let's have a little look at what we're going to be doing, what you guys are going to be doing anyway.
Remind me.
Remind you. Yeah, this is why I use this screen as well. Again, if you listen to the podcast and you want to see the images, we'll talk through the images, but I've just got them up here for people who've joined us live. And if you are listening live, then don't forget, feel free to ask questions. This is your chance now, because you are going to have to make some choices. We've got a main theatre and we've got a breakout room. We've got things happening at the same time. So you're going to have to make some decisions based on what's going to be most useful for you. Whether that's reinforcing something or something that's going to challenge your biases.
No silly questions unless you ask them twice.
Ask some questions. I've got one comment there, and that's just checked. It's probably that Nikki Mansfield. No, it's not. It's Deborah Thurlow-Rowley. Hi, Deborah. How are you? It's not a question.
Hello.
I think it's just admiration, and rightfully so. Deborah Thurlow-Rowley has said, "Always great to hear what Claire has to say." There we go. Thanks, Deborah.
So thanks for
good to see you.
Checks in the post.
Right, let's go back to Claire first, if we can. So, Claire, you are going to be gracing the stage. First of all, on the Saturday, that's going to be 10:30 a.m. in the morning in the main theatre, with the title of the presentation, Strength and Conditioning for Preserving Joint Health.
Yeah.
Don't give too much away, but
the theme of our my talk, and obviously Serena and I are doing a session in the afternoon together. So Anna Marie asked if we could present on joint approach and the principles about joint approach, which is an online multidisciplinary program for the management of knee osteoarthritis, which I've already mentioned, which has had a profound impact on individuals suffering from knee OA from early stage, but also to very late stage knee OA. So it comes back to what I said about dealing with the whole person. So I have an expertise in exercise science, rehabilitation, neuromuscular physiology, but to think that I was the only answer to somebody's rehabilitation needs is quite short-sighted, should we say. We have a whole and complete being, or we need a joint approach from psychology, from education and clinical input, and also nutrition to give that individual the best shot to, I'm not saying get better, but have a much better quality of life, reduce pain, etc. So from my perspective, we can really do this exercise interventions far better than we are doing already with some really simple things. So strength and conditioning is, and it still remains the kind of buzz phrase, it's all about exercise prescription, which doesn't sound quite as sexy as S&C, but it is basically that. What is the type of exercise that we're giving? How intense do we need to deliver that? And then also then in front of you, look at what that individual is struggling with in terms of pain, particularly, and can we modulate and adapt exercise to take account of pain before we start, for example, to reduce load. So for example, again, some of the really important things include muscular strength. So muscular strength is so important for a multitude of reasons. It is related to incidence of disease, all-cause mortality, quality of life. And then also we can look at the joint surface and joint health too. So if we're going specific into knee OA and joint surface, an experience of pain from joint surface changes, it has a profound impact. Then how do we start to deliver and prescribe exercise that's got the best shot of improving muscular strength around the joint? The musculature is like your biological scaffolding. How can we best condition that in an individual who is suffering from knee osteoarthritis to help the joint that's suffering from knee osteoarthritis? And also just to acknowledge that joint health can go back from or to a very young person, and we're thinking about injury prevention, through then to perhaps NSTEM PIC OA as the condition prior to knee joint replacement surgery to optimize that outcome. And we have multiple touch points in there where we can use these principles whenever we encounter that individual or those groups of individuals to optimize our exercise interventions to improve these parameters, which will then mean maybe that individual actually doesn't have to go for joint replacement surgery because they're feeling so much better. Coupled, might I say, with all the extra stuff about, with the psychology and understanding of pain and what it is and what it isn't, and finding their support network, etc. Right back to, as I said, kind of thinking about injury prevention and conditioning at an earlier age. But from my perspective, we're going to be talking in this conference about knee osteoarthritis and some really simple things that you can use in your practice to help just tweak those exercise prescriptions that you're giving for a best input-output equation. So what you're doing with your patient, what your patient's doing with the exercise.
Fantastic. Sounds amazing. And it sounds, one of the most common questions I get from massage therapists, particularly those who qualified after kind of 2014, is they hadn't done any strength and conditioning.
Mm-hmm.
They really are aware that what they have developed, and I think this is where the power of massage comes from, is they have normally developed some fantastic empathy and communication skills, even if they're not aware of it, because they're the sort of person who likes to earn not much money rubbing their hands through a hairy back with oil on it. So they are caring people, so, and God bless them, and they form such an important part of the circle of health for clients. But for people who are massage therapists and looking at learning some strength and conditioning principles, this will be useful for them to come in and know what they can maybe should be doing themselves, or how to refer it out, and just to be able to refer out. I think that's so important, just to be able to flag up certain things and suggest that patients go to other people.
Yeah, absolutely. And also, so as I don't know if listeners know, I'm so fortunate to be able to teach multiple kind of groups of people around the world on these topics, which include sports medicine doctors, physiotherapists, sports massage therapists, anybody who's got an interest in rehabilitation, to help the practice that they already deliver, help optimize that. So one, there's that, and then two, absolutely, and Serena, I've talked about this before, where you acknowledge there's a need greater than what you're able to deliver, but you're all working with the patient at the heart, or the client at the heart of your practice, and actually forming those relationships with people you know, like, and trust is not giving business away. It's strengthening your practice, and you fall from this positive cross referral relationship. So there might not be, you give out or you refer on to this practitioner, and likewise your area of genius and expertise will be reciprocated with that the relationship, where they refer back to you, other patients and clients. So absolutely what you're saying there.
Fantastic. So yeah, I mean, that's why the catchphrase of our conference is pause, reflect, and connect. When we're talking about connecting, we're not talking about connecting with just people who do your job. We're about connecting with other professionals in healthcare, because it is a great.
It's a joint approach, isn't it, Matt?
It's a joint approach. You should trademark that. That's a fantastic idea. What a great company. No, it's beautiful. I'm really looking forward to that. Definitely. Fantastic. Right. I'm conscious of time. We're going to kind of come back to that when you mentioned already the joint afternoon session you're going to do with Serena, but let's move to Serena's. I'll read it out, the presentation. So Serena's is going to be later on at 12:15, and it's called Beyond the Treatment Couch, The Hidden Power of Words, Belief and Behaviour. What would you like to say about this? How's it going to help people who come along to see it?
Do you know what, Matt? I'm just very much thinking I've talked far too much tonight, so I'm going to keep this really brief. You've said it all in the title. What I want for people to have is, I want them to go away thinking that they've learned more about how people think and respond and behave, and why they do what they do, really. I'd love to give people more of an insight into maybe what they're seeing in their treatment rooms, and why people are doing the things that they're doing. So actually, I want to go into that room and hear more about what other people have experienced, and help them to make sense of that, really. And for me to try and unlock some of that for them from a psychological point of view, so that they can go and try some things when they go back to their treatment rooms on Monday. Because there are some really quick kind of wins that we can kind of have and I can give to people, where they can try things really quickly. And I think the beauty, I hope, of what I teach with psychology, and the thing that actually, one of the things I should say as a little side note that always makes me smile is the thing about psychology, and I'm doing it again, I'm putting my hand up.
That's fine, you go ahead.
Is that, actually, this is the authority finger, not the hand. Okay. Is that when you're learning about human psychology, you're also learning about yourself. Mm-hmm. And so one of the biggest compliments I get, it really genuinely, like my heart just kind of hums, is people say, do you know what, I did your course, but I've been doing that thing you said with my children, and it's really working. Or I use that thing you said about how to communicate with my husband, and oh my God. So that's the beauty of understanding how someone thinks and feels and behaves, is that it's not just applicable in the treatment room, and it will do that. It will change that, I hope, as well, and it does. Kind of jokes aside, but it has a ripple effect in terms of other relationships, because understanding those things just has that kind of universal impact. So that's what I hope to have. Amazing. That sounds actually quite big, but yeah. Hopefully you can take one thing away.
It's great, because it summarises exactly what we're trying to achieve in the conference. And I'm hoping listeners have read our kind of, go to the @school.co.uk and have a look at what we've written on the webpage, because the whole idea of the conference is, it's not just another conference where you're going to go along and listen to amazing information, because that might be amazing information, but it's all about how it's delivered and the learning cycle. And normally 9 times out of 10 about you being involved during it, being given a chance to reflect, because that's how we learn. It's education, as opposed to just, there's a place for kind of lecture halls and people just sitting there and not talking and listening to the person at the front. But what we're trying to do with this conference is help people who come along really walk away with empowered and with some information they can use, something functional, something useful. And it's thanks to deliverers like yourselves, educators like yourselves, that I'm confident that that's going to be achieved, because you've both, I know you both do this.
I make it a thing, actually, Matt, and anything that I deliver, whether it be a short free seminar or webinar or indeed a course, that there needs to be at the end of that, and especially the scrutiny, I suppose, is especially on those short things, that people can go away and practically implement something from that session. Otherwise, it's a nice to know, but what do I do with that? And invariably, all the people, majority of people that I teach and interact with are involved in changing people's physical status and mental, psychological status, although I don't have the psychological expertise or input like that. If they can't go away and use that, what's the use? It's been nice, but everybody's got such a busy life. How many people can go away and read the latest research articles, critically evaluate them, and then try and understand what that means for their own practice? So if I'm able to do that, that's absolutely my pleasure. And every single session, I make sure that is in there, at least one thing they can go away and try as soon as they get off the call. Otherwise, if it were me sat in that seat, I'd be like, but how do I do that?
Yeah. Brilliant. So exciting. Can't wait. Right, and then as you already mentioned as well, there's going to be a joint presentation which is going to be later on in the afternoon, and that's going to be 1:40. Both of you are delivering a workshop in the breakout room entitled Why Rehab Needs a Joint Approach. And I guess that's kind of what we talked about, the two of you coming together and be able to show that this is a person we're working with.
Yeah, I'm really excited about this one because we've got some case studies, haven't we, Claire? So brilliant. Massively changed. I think this is the beauty, we get to show what happens when you bring that knowledge together. I think I don't know what Claire knows. I haven't got a Scooby-Doo. I've learned a bit over the years, but
likewise,
I think what this shows for me is psychology. As I've illustrated probably in what I've said, is the basis. I think it's the start, but you've got to back it up with someone. If you're helping someone change their physical strength, you want to rehab them, they won't think themselves better. So that's the starting point. And then they need to do the thing.
I think, violently agree. In so much as, let me just give you, I know we're short on time, quickly exemplify this. So in the trial that I mentioned, so we did a load of objective data collection and also qualitative as well. So through interviews and questionnaires and properly evaluated. So individuals that were on this program were in this particular group were 2 to 4 years on a waiting list for knee replacement surgery. They were in such incredible pain. They couldn't navigate the stairs, majority of them. Some had put beds in their living room. Some had, it was just horrifically horrible for them. Now, this is a 12-week program. Within 2 weeks of this group being on the program, many of them, if not the majority, well, definitely the majority, if not all, were reporting improved pain. So the pain levels were going down. That's not a massive physiologic change. We know that strength will take a bit longer than that, even neurally, to change. So that, for me, is a psychological relationship, understanding of what pain is, what it isn't, that it relates to through the education that we've got on there. It doesn't mean you're doing damage. And that is profoundly impactful, because then that means they can engage in the strength-based exercise, which requires, for them, like a pretty extremely intense effort to push and pull against these heavy-duty resistance bands, etc. But it gave them the confidence to do that. That's the bit that creates a lasting physiologic change, which then, again, this is all hypothesized, the change in pain thereafter, which we also saw again, so a continued improvement in pain, continued improvement in quality of life, continued improvement of function. And then just to come back to the psychology bit is recognizing what they're going to do after the end of that program. So we don't want people to just stop. We want them to become independent, confident exercisers. And if they fall off the wagon, which everybody does, and that's fine, how to get back onto that cycle of behavior.
Can I just say one last thing, which is one of my favourite phrases, which tags on to the back of what Claire said, which is change is not just for Christmas, it's for life. Because I think a lot of strategies that you learn around behaviour change are great, because what they create is compliance in clinic, and that's it. And I think the difference between a compliant person / patient / client, whoever you're seeing, versus that person where you upskill them enough that they've tapped into something deeper psychologically, so it means something different, that the behaviour change is sustained over time. That's when you've really done something great for another human being, and you've not just done your job. And I think that's the difference. That's what I'm after. So the work I do, that I'm kind of collaborating with Claire on, with Joint Approach, an amazing company, is to help that behaviour change be sustained and not just basically to go beyond the program itself. And I think that's the power of it.
Fantastic.
Yeah.
That sounds amazing. It's going to be such, if anybody's planning on coming along to my presentation, if you've got any of these guys at the same time, then this should seal the deal for you. Just go along to them. Honestly. I might have to rearrange the time. I'm organising the timetable. I might have to play around with this now. Although, if it is the same time as you can't come and see mine, so that's
I'm
good.
going to come and see yours.
I'm pretty much going to make sure shortly after this you can't. Anyway. So yeah, there we go. Brilliant. So much said that is kind of exactly what this conference is about. And you are 2 of 19 speakers who I like to think, as we selected them, are all kind of on the same page. And it's going to be a great event. So thank you so much for coming along to it. If listeners have heard you and they can't come along to this, but they want to follow you and maybe get and find out about courses and things, what's the best way for you, Claire? It's the website, getbacktosport.com.
Getbacktosports.com. You can find everything on there. So online courses on strength and conditioning, dynamometry, some in-person courses as well. Although probably most of those are in-house, but you might find the odd one. And on social media. Feel like you
when you say in-house, you're based where these days?
Nottingham. I'm in Nottingham, but the in-house courses are all over.
Oh right, I see what you mean in-house.
There's a really good one if you fancy a holiday. There's one in Abu Dhabi in
I saw
in
that
November.
advertised.
Yeah. It's not advertised.
Maybe next year. Brilliant. And yourself, Serena, if people want to follow you, you've got the psychologyschool.co. That's an interesting one. Just repeat that for listeners. It's .co.
Actually, I honestly think I've got both. So if you put .co.uk, it should also go to
.co. Oh, that's cool.
I think it does.
Nice.
Yeah.
That's clever.
And then in terms of work, I have got a course, the Behaviour Change course, which is a 5-week online course that I release once a year. So there's a page on my website. Just go to that, sign up to the wait list. And then my main focus now is Psych which is my exclusive membership, which is really for female. I say it's for female practitioners, but actually we have men in there, which is amazing. I love it because they're like, sod that's not just for women. I'm coming in, and it's not. We don't look at anything inherently just female. It's just most of the women and people in there are female, and it's a closed community for people who would like to learn psychology and behaviour change ongoingly. So as a community, we have a masterclass every month. I bring in amazing guest speakers. I train in there. We have coaching calls every month. We have a book club. We have kind of work together sessions. Amazing. People like Claudia Hammond have come in. We've got amazing guest speakers coming in. So that's opening again this month. Twice a year only. So
That's all available at psychologyschool.co if they go there.
Yeah.
Site
It'd be
nav.
lovely to see more people in.
Amazing. Even if you're a man. Fantastic.
Even if you're a
You heard it
man.
here.
And actually, Anna, I'm going to name drop. Anna is in it.
Oh, Anna Maria Sierra is there. Fantastic.
Yeah.
Of course she is. She's everywhere. Wonderful. Right. So we'll make sure these links go into the show notes as always. It's been absolute lovely spending time with you, and can't wait to see you guys in less than 3 weeks now. So very exciting. People who joined us live, thank you very much as well. If you're listening to the podcast, and obviously thank you. We'd love to see you live. I understand for some of you, you're working and it's tricky to come along. But if you can make a lifestyle change, if you're struggling with that, then go to Serena Simmons, and she'll help you along with it. But if you can make a lifestyle change and give more time to yourself and living in the present, then maybe come along to YouTube on a Tuesday, normally at 8 o'clock, and hang out with the other people in the live lounge. And you can ask questions to our guests directly. If you listen to the podcast, and obviously thank you very much as well. We do appreciate that. But we'd appreciate it even more if you could subscribe to the YouTube channel and also just leave a rating and a review on whatever podcast app you listen to, because it just helps it appear high up in Google, particularly if it's Apple or YouTube. It just helps the good word of our guests get out there more, which is what it's all about. It's all about just being a conduit for great information. So yeah, do your bit by subscribing and liking and all that sort of stuff. It really makes a difference. As I say, we'll be back next Tuesday when my guest is going to be, we've had enough. Anna Maria's got a massive shout out so far today, hasn't she? Yeah, once again, we're going to say Anna Maria Mazzieri will be here next week, director of the ST School, who I think is going to be a really interesting conversation about what is evidence-informed practice, something that you guys have asked to have clarification on. And Anna Maria will be linking that with a couple of presentations she's giving in September. To do with pain, trauma, and also manual therapy for scars. So if you can, join us for that. Next Tuesday, 8 o'clock. But in the meantime, just once again, thank you so much to Dr. Claire Minshull.
Absolutely my pleasure.
And Serena Simmons.
Thank you, Matt. You're a great interviewer. And thank you to Nikki, who said something lovely. Thank you.
Oh, if we've got a comment, let's bring that up then.
Just thank you for being here for you both. Thank you. See you in September. So see you there.
Thank you,
Nikki. How nice of you. Thanks, Nikki, and thank you everyone who joined us live. I mean, it's not as many. It used to be like 80 or so. It's not as many, but we still do it live because the feedback we get, even from people who download it, is we love it. It's the fact it's live. So this is why we do it live. But if you can join us, then even better. That'd be lovely as well. And so Glenn Murphy can have the final word, obviously, because he's a Sir. Nice.
Oh, thank you.
Thank you, Sir Glenn. Thank you very much. Right, take care of each other and look after each other. Bye-bye.